Hadirin yang dihormati, mengumumkan ketibaan Yang Berbahagia Profesor Datuk Dr. Rohana Yusof, Timbalan Naib Chancellor Haliwan Pelajar Universiti Malaya, Profesor Dr. Khoo Ming dan Dif-Dif Kehormat masuk ke Dewan. Hadirin dipersilakan berdiri. Lagu Negaraku dan lagu Universiti Malaya. Assalamualaikum warahmatullahi taala wabarakatuh dan salam sejahtera. Yang Berbahagia Profesor Datuk Dr. Rohana Yusof, Timbalan Naib Chancellor Haliwan Pelajar Universiti Malaya. Yang Berbahagia Profesor Datin Dr. Hamimah Hassan, Pemangku Dekan Fakulti Perubatan. Yang dihormati Profesor Dr. Khoo Ming, Profesor Nigel Maters, Vice Chair of Council, Royal College of General Practitioners, United Kingdom. Dif-Dif Kehormat, Barisan Pengurusan Universiti Malaya dan Fakulti Perubatan, para jemputan, hadirin dan hadirat yang dihormati sekalian, selamat datang ke Syarahan Perdana Profesor Dr. Khoo Ming yang bertajuk Primary Care Research, A Personal Journey. Hadirin yang dihormati, majlis dengan segala hormat yang persilakan. Yang Berbahagia Profesor Datuk Dr. Rohana Yusof, Timbalan Naib Chancellor Haliwan Pelajar untuk mempengerusikan syarahan perdana ini dan seterusnya memperkenalkan Profesor Dr. Khoo Ming.
Terima kasih pengacara majlis. Ya. Yang berbahagia, Datin Profesor Dr. Hamimah, Deputy Dean, Fakulti Perubatan, Professor Nigel Matters, Vice Chair of Council LCGP UK, and yang diraikan Professor Khoo Ming. Ladies and gentlemen, hadirin hadirat sekalian, Assalamualaikum warahmatullahi wabarakatuh. Let me do a brief introduction of Professor Khoo Ming. There's a lot that I can read about her, but I think I'll cut it short because I'm sure you want to listen to her. All right, so let me introduce Professor Khoo Ming. Professor Khoo graduated from St. George Hospital Medical School in London, UK in 1986. She subsequently received her vocational training in general practice and obtained her professional postgraduate degree, MRCGP, from the Royal College of General Practitioners, UK in 1991. She practiced as a general practitioner at a group practice in Huddersfield, UK until 1993, when she returned to Malaysia and joined the Department of Primary Care Medicine at the University of Malaya until now. In 2002, she was awarded the World Health Organization Fellowship to look at the development of health system based on primary care at the University of Sydney, Australia. In 2006, she was awarded Fellow of the Academy of Medicine of Malaysia, and the same year, Fellow of the Academy of Family Physician in Malaysia. Professor Khoo was appointed the head of Department of Primary Care Medicine, University Malaya, in 2006 to 2009. In 2007, she joined the National Specialist Register when this was first introduced by the Ministry of Health. Amidst her work as the head of department during this period, she pursued her research work on somatization disorder in primary care and was awarded the Doctor of Medicine degree from the University of Malaya in 2010. Professor Khoo has been actively involved in the development of postgraduate Masters of Family Medicine program at the university and at the national level. She is the overall coordinator for the Master of Family Medicine program at the University of Malaya for more than 10 years. Throughout this year, she has successfully supervised 19 candidates of the Master of Family Medicine program to completion and 11 master candidates still ongoing. In the recognition of her service and contribution to the university, she was awarded the University of Malaya Excellence Service Award in the years 2000, 2005, and 2006. Professor Khoo's professional standing has also seen her being appointed as the external examiner both locally and internationally. Professor Khoo has published many papers in peer-reviewed journal, books, and book chapters. She has presented at many scientific conferences and has also organized many conferences, workshops, seminars on primary care research and clinical medicine. Her particular areas of research interest include chronic diseases, men's health, women's health, and mental health. She is actively involved in primary care research, health system research, and clinical trials. She's also a committee member and member of a guideline developing group for many clinical practice guidelines aimed primarily at primary care physician. These include clinical practice guideline on hypertension, diabetes mellitus, dengue and dengue hemorrhagic fever, growth hormone, chronic obstructive pulmonary disease, neuropathic pain, and screening. Indeed, she conducts research involving multidisciplinary team, and she bridges the gap between universities, academic, and Ministry of Health through her research. Apart from the research and publication, she is an editorial board member of the Asia Pacific Journal of Public Health and a Malaysian Family Physician Journal. She was also the past editor-in-chief of the journal Family Physician in Malaysia. She is a panelist for Star Health and Aging, advisory panel on Age Well column and the section on Fit for Life, which features different topics on health issues every fortnightly on Sundays in the Star newspapers to promote health-related matters to the public. Ladies and gentlemen, with such a wonderful credential, it is an honor for me to invite Professor Khoo Ming to deliver her inaugural lecture. Primary Care Research, A Personal Journey. Professor Khoo, the stage is yours.
Yang berbahagia, Profesor Datuk Dr. Rohana Yusof, Timbalan Naik Chancellor Hal Ehwal Pelajar Universiti Malaya. Yang berbahagia, Profesor Datin Dr. Hamimah binti Haji Hassan, Timbalan Dekan Ijazah Pertama mewakili Dekan Fakulti Perubatan. Professor Nigel Mathers, Vice Chair of Council, Royal College of General Practitioners UK. Adjunct Professor Datuk Dr. Turayapa, Chairman of Council, Academy of Family Physicians Malaysia. Dr. Goh Pik Ping, Head, Clinical Research Center, Malaysia. Dekan-dekan, timbalan-timbalan dekan, Div-Div Kehormat, Barisan Pengurusan Universiti Malaya dan Fakulti Perubatan, tuan-tuan dan puan-puan sekalian. Selamat petang dan salam sejahtera saya ucapkan. Izinkan saya meneruskan syarahan saya dalam bahasa Inggeris. Good afternoon, ladies and gentlemen, friends and colleagues. Thank you for attending this lecture amidst your busy schedule. I know 3:30 is not really the easiest time to come, and yet you made it. Thank you. Well, research and publications, they are core functions of us in the academics. But are we doing it for university ranking? Or is it really about truth finding? Are they providing us with the evidence that we need for clinical practice? Or should we be broad-based, as in our discipline? Or should we be focused in our research endeavor? Should we be doing in-depth knowledge in a specific area? Or should we be very general in our approach? We are often straddling a path between our academic inquisitiveness versus our clinical enhancement. And these decisions in our academic careers are sometimes as uncertain as we undertake any major life decision. We all know that primary care is the richest ground to generate questions for research that will provide us with evidence of our clinical practice. And it is this enthusiasm in clinical practice that often is the impetus that let us carry on with such research. History has long told us that research in primary care all stems from our interest in our patients. From the 18th century, the discovery of vaccine in smallpox by Dr. Edward Jenner, to the 19th century of the transmission of yellow fever by mosquito by Dr. Finlay, a Cuban doctor, and the 20th century about the identification of infectious diseases by a GP, Dr. William Pickles in Yorkshire. All this has informed us that clinical questions generated through patient care led to better understanding of the diseases and in turn promote better health care. However, although we know that the majority of patients that are seen in primary care, but the minority is actually done here. The reasons include lack of research training within primary care, time constraint, lack of space, fewer academic centers in the country, and funding issues. So the challenge for us in primary care here is really to enhance our primary care capacity, create strong infrastructure to engage primary care physicians in this research arena. And to do this, we have to strengthen our academic departments, we have to enhance our links to researchers in other fields, we have to improve our training programs for future primary care practitioners and researchers, and we have to develop more practice-based primary care research network. And of course, we have to increase funding for general practice. Research in primary care is essential to inform clinical practice and to develop better health system and health policy. We need to be an integral part of this research world so that the right questions are being asked, the research findings are being applied to our practice, and that evidence-based approach to primary care practice is the norm. So my journey begins when I stepped into this department, our Department of Primary Care, in 1993. At that time, coming back from the UK as a practicing GP in the Yorkshire region, I have no clues about what happened in general practice in the country. So naturally, being very strong in practice management, that is our first research endeavor. We did a survey of our GP tutors that is teaching our undergraduate program in University of Malaya. And we found that half the GP then, the GP tutor, had postgraduate qualification, and half of this qualification are GP related. Half of them were solo practices, 60% of them have computers, but at that time it's only using for word processing. Most of the tutors have a personal workload of less than 20 patients per day, and only a third of the practices employed quality nurses. But of course, most of these practices are well equipped and provided a comprehensive range of services. So, knowing this in mind, 2 years later, we embarked on another research that goes nationwide, and we surveyed 1,171 general practices in the country. And it tells us that 6% of our GP actually possesses a postgrad qualification in primary care medicine. And what this is telling us is that our postgrad training is still in its infancy in Malaysia at that time. Only 4% did research in the previous 3 years. 75% of them are running solo practices, and nearly all the practices were open 6 to 7 days per week. And the mean workload per doctor per day was 45, and 43% of them had a computer. Then I looked at all these practices and compared the east and the west of Malaysia. As we all know that east and west Malaysia are differing in our accessibility to healthcare, in our geography, in our culture. And we found that the practices in East Malaysia, most of them are providing services for sexually transmitted disease, but many of them are not providing counseling services for sexually transmitted disease or marital counseling. What is that telling us? It's actually telling us that we are very disease-based at that time, and we are not putting much emphasis into patient care, in being patient-centered. So in 2002, I went to Australia, being attached to University of Sydney, under the WHO fellowship to examine general practice structure in Australia and in Malaysia. And I looked at the general practice structure in these two countries and found that we are fairly similar in our service provision, but our fee payment structure are different. Both of us are moving towards preventive health care, and we are centered into chronic disease management. That just shows that we are moving more affluent in our society. However, we are still putting emphasis in our rural and aboriginal health issues. Despite that, there is a difference between the two countries though. Our quality of general practice in Malaysia, the delivery is quite variable, because a general practitioner can register and set up a practice with a GP basic degree, with a basic degree. I've moved on so fast. Now I have to move backwards. Never mind. So what it means is that, with a basic degree, we can set up a practice. But in Australia, you can't do that. They started the compulsory vocational training in 1990. And in the first transitional period, for the first 5 years, they allow all the GP to be registered if they have a GP experience of 5 years. And now with our present system of One Care and healthcare reform, it is quite timely really for us to look forward and think, is this the way that we want to move forward? Because certainly setting a standard for primary care is one of the prime issues that we need to look at now. And it's been long overdue, and we really need to settle it now. From primary care, I move on to mental health. And we all know that we see lots of patients in primary care where 50% of them cannot be explained the symptoms of. We cannot use our medical model to explain that. Really don't know why they come and see us. And we know that somatization is very common in all ethnocultural groups. And yet, there's not been any study done in Malaysia. None at all. Despite we having the richness of the culture and the diversity of the culture here in the country. We did a pilot study on the prevalence of somatization in primary care attenders from 6 ethnic groups in the UK and Malaysia. We found it difficult with regard to cultural and operational issues on somatization in this study. But in both our countries, we find that the presentation of physical symptoms could be used by the patients from different culture as an admission ticket to a doctor for validation of sick role, or as a reluctance of them to admit to mental health problems. And this has led to my doctorate degree on the questions that how common really is somatization disorder in primary care attender in this part of the world. Somatization disorder is characterized by chronic disease, chronic syndrome of medically unexplained physical symptoms in the absence of major psychiatric disorders. And it has been defined in so many different ways that the prevalence estimates has ranged from 0.03% to 35%, according to the healthcare setting, according to operational criteria used, and the ethnic group surveyed. We know that from literature it's actually associated with general anxiety disorder and depression. It is also associated with occupational and social disability, psychopathology, and functional disability. It is also associated with impaired health-related quality of life. And yet, its association with other demographic, like gender, age, is really inconsistent. We know that somatization disorder has led to extensive investigations and caused excessive healthcare utilization, referrals to secondary and tertiary care, and increased medical costs. However, as we mentioned earlier, there has no study yet done. So there we go. We've done a study on healthcare centers in 3 healthcare centers in Selangor. We recruited 1,763 patients in these centers. We use a very stringent criteria for diagnosis based on ICD-10, frequent attenders, as well as excluding moderate and severe anxiety and disorder. The mean age for these patients were 45 years, and we found the prevalence of somatization disorder was 3.7%, which was consistent with studies done elsewhere. And we found that Malaya has a very high prevalence of 5.8%. We also asked the doctor to use their clinical judgment to diagnose somatization disorder, and we found that they only diagnosed 2.7%. And they say probable SD is 8.8%. And the doctor's positive predictive value for diagnosis is only 5.4%. This suggests to us that we really are uncertain about making a diagnosis of somatization disorder. Why is Malay having such a high prevalence? We really are not sure. But perhaps we can think that this could be reflecting a true difference in the prevalence, or it could be due to a difference in the instrument translation. Or perhaps it could be due to the cultural factors that so often influence our meaning attached to the symptoms and presentations. It could be our differences in the idioms of distress and psycholinguistic expression of emotional states. It could also be the familiarity with pathways to healthcare. And in the Malay ethnic, it is also possible that their accepting nature in the belief system, their perception of illness and health as fate, may have suppressed the effect and translated to somatic symptoms and complaint. Blue-collar workers, we know, are the physically demanding job. And it is also possible that the nature of this occupation has an influence on somatizing behavior. In Malaysia, medical certificates allows for paid time off work, as often we call it MCs. So somatization does allow them to legitimize their sick role in a society. And knowledge of this finding allows us to better identify patients with somatization disorder in primary care. What my thesis has suggested is that we need to redefine the definition of somatization disorder in primary care, as there is a lack of standard definition could actually cloud our diagnosis and our management in our patients. And indeed, in the DSM-5 and ICD-11 that is going through revision currently, they are talking about revising the category of somatoform disorder. From somatization disorder, we moved on to somatization. We found that 66% of the patients in primary care attenders have more than one medically unexplained symptoms. This fits in with our hypothesis that somatization is indeed common in primary care. And in our local setting, they commonly present with bloatedness, numbness, tingling sensation, pain in the limbs, extremities, in the joints, abdominal pain. We know that different cultures have different beliefs about health, illness, and use of medical services and treatments. And all these symptoms presentations are all well known are culturally mediated. Certain illnesses may be stigmatized within different cultures, and our patients may present with symptoms that is acceptable within their own cultures rather than those that conform to our Western model of diseases. Therefore, a knowledge of our patients' cultural and religious belief and practices will facilitate our effective communication, allow accurate diagnosis, and share decision-making on our management made with the patient. We need to be skilled in eliciting and understanding cultural issues and values of our patient, and learn to work with our patients, their cultural values, especially patients with somatization in transcultural consultations. From mental health, we move on to women's health. In 2007, our National Cancer Registry has stated that cervical cancer is the third most common female cancer in Malaysia. We have cervical cancer screening program established way back in the 1969. Despite that, our pap smear screening coverage is so poor. In 1996, our National Health Mobility Survey 2 has shown that only 26% has been covered, and it's no better today either. Therefore, in 2005, we embarked on the qualitative research, looking at the knowledge, attitudes, and beliefs of Malaysian women about pap smear screening. And we found that the women really do not have a clear understanding of the need for early detection of cervical cancer. They do not really know the meaning of abnormal cervical cancer pap smear. Many believe that pap smear was a diagnostic test and is not a screening test. Since they have no symptoms, they do not need to go for a pap smear then. And other main reason why they don't go for screening is the lack of awareness of what pap smear does and its benefits, and its also perceived low susceptibility to cervical cancer. They don't think they are going to get cervical cancer at all because they think they are at low risk. And the other major issues is embarrassment. That's so much culturally linked. Women are not aware of what human papillomavirus is. And this really highlights the importance to us that if we are going to design an intervention about pap smear screening, we really need to look at disseminating the accurate information about cervical cancer and its purpose in screening. Dysmenorrhea is a common gynecological symptom in girls. We surveyed 1,000 girls in Kuala Lumpur. more than 3/4 of them who have reached menarche has dysmenorrhea. And half of them say it has affected their concentration in class, and it has restricted their social activities. 1/4 of them said that it caused them to miss school, and they have poor school performance. And yet, only 10% of them actually come to see the doctor about it. And we found that there are strong associations with ethnicity in terms of the prevalence, impact, and management of dysmenorrhea. So culture-specific education about menstruation-related conditions in the school curriculum is much needed. Then we look at the antenatal mothers. We know that routine rubella antibody screening is not done in Malaysia. And yet, congenital rubella syndrome has persisted with its associated health burden. We recruited 500 pregnant mothers in the Selangor district, and we did a rubella IgG test. And we found the prevalence of rubella susceptibility to be 11%. And a history of not having received rubella vaccination or having unknown rubella vaccination status was a significant predictor. So, ladies and gentlemen, a simple question is enough for us to have a clinical important question and status. Much of the emphasis has been placed on women's health until about a couple of decades ago. And yet we know that men have shorter lifespan than women, and they are less likely to seek healthcare attention. They are at higher risk of cardiovascular disease, of accidents, of cancer, of sexually transmitted disease, and sexual dysfunction. They are indeed a neglected high-risk group. It is really our job as a primary care physician to take an interest in them, to investigate their healthcare seeking behavior, and to think of strategy and treatment for their well-being. We did a survey on 351 men over the age of 50 in the Subang Jaya district. We found that the prevalence of erectile dysfunction is 70%. And 30% of them have moderate to severe lower urinary tract symptoms. 11% of them had severe depression. 30% have self-reported hypertension. 21% self-reported diabetes. 11% self-reported coronary artery disease. And the list just goes on and on and on. They are really not well, are they? So we need to look after them. We next embarked on looking at another problem in men. We surveyed 200 men that attend our clinic between the age of 18 to 70. And we find that the prevalence of premature ejaculation was 40%. 40%. And it is found to be associated with erectile dysfunction, circumcision, sexual intercourse of less than 5 times in 4 weeks, and Indian ethnicity. Of course, this study needs further confirmation. But what it tells us is that we need to explore all these sensitive issues with our patient, these common problems with our patient who will not otherwise not have brought up this matter with us. Chronic diseases is a heavy burden in our country. Cardiovascular disease is a common killer in our country. In our National Health Morbidity Survey 3, more than 30 years of age, a person more than 30 years of age in Malaysia was found to have 43% having hypertension, 15% have diabetes. It is not surprising that the bulk of our care centers around hypertension, diabetes every single day. So naturally, we will do research in this area, won't we? So in 2003, we surveyed 500 patients with type 2 diabetes in a health center in Malacca. And we found that half of them have HbA1c of more than 8%. And 24% of them had microalbuminuria. But note, 70% of them had hypertension, of which only 3% of them have achieved a target blood pressure of less than 130/80. Of those who have not achieved the target blood pressure, 40% were not on any hypertensive medications. And only 20% of the patient with type 2 diabetes and hypertension were prescribed ACE inhibitor. So, 3 years later, 2006, we did another study in our own center with 200 patients with type 2 diabetes. This time, the mean age was a bit higher, 62, and the duration of diabetes was 12 years. And we found that a quarter of the patient achieved HbA1c of less than 7%, quarter achieved the target blood pressure, a quarter achieved the LDL cholesterol of less than 2.6, and yet 16% is on subcut insulin, and our management is not optimal either. 2 years after that, in 2008, we looked at 79 public health centers and 33 GPs from a random selection of 100 centers and 104 GPs in Malaysia. We reviewed 4,000 records, and we found that less than 80% of them documented recommended clinical and laboratory assessments. Overall, 21% of those prescription practices were less than optimal. The process of care and the use of antihypertensive was just not satisfactory. The underuse of the ACE inhibitor and other therapeutic management should really lead us to reflect on our strategy to better improve our management in hypertension. This health system research provides us with the evidence to address the deficiency we have in our existing system. Apart from disease, what about other aspects of primary care? Spirituality. We looked at 200 patients again, and we looked at the religious affiliation. And we found that higher religiosity amongst the Muslim does have a significantly better glycemic control among the patients. So it does suggest to us that spiritual beliefs do play a part in chronic disease management. With the range of disease, we must look at the range of the research methodology, from quantitative health system research, qualitative research. We also embarked on investigator-initiated drug trials on hypertension. We also moved to asthma, which is another important chronic disease in the country. And we looked at people who present with asthma in emergency department here in UMMC. And we found that 3/4 of them who come with asthma has poorly controlled asthma. If you notice, less than half of them were on inhaled corticosteroid. 1/3 of them did not have a regular follow-up. And half of them could not actually recognize features of worsening asthma. 60% of them do not know the difference between reliever and preventive medications. Only 9% of them use peak flow meter at home. So we have a long way to go in our management of patients with chronic diseases, which is a big challenge to us in primary care. The strategy for intervention, I believe, will be the next wave of research for us to improve care for chronic diseases in our country, and indeed worldwide. Patient safety has all been a core issue in all our clinical practice, and yet we can hardly find any research done in patient safety in the country. In 2007 to 2008, we did a complex intervention on patient safety in 12 health centers. We reviewed the record, at which is majority are seen by medical assistant. And it is really alarming to see that nearly all the records have documentation errors. 1 in 2 of the patients have management error. Medication error is as high as 40%. Diagnostic error is 4%, but that's with a caveat of inconclusive diagnosis of 60%. and that 1/3 of the patients have errors that are likely to cause serious morbidity or mortality. So we invented and developed an intervention package that involved system change, clinical audits, and tool. And this is our beautiful calendar flip chart that sits on like a desk flip chart. And inside it is all about diagnosis and management of common diseases, diabetes, hypertension. How do you diagnose? How do you treat? And we found that this intervention has effectively changed documentation. And medication error has been reduced in the intervention clinic. So a structured medical record is useful. Quick flip chart with the concise diagnosis and management was very well received, and it has now been disseminated and used in health centers to improve patient care. Here is an illustration of knowledge translation in healthcare. Well, one of our frustrating tasks in conducting research early in years is the difficulty of locating our local data and literature, because there's just no systematic record of research in the country. Many of these research are published in abstracts, reports, non-indexed journals, monographs that we cannot find. So this shortcoming was indeed the impetus for us to do a collection of bibliography of primary care research in Malaysia. And we collected research output from Malaysian primary care settings from 1966 to 2003. We found and retrieved 1,222 papers. And it is, as you can see, the number of publications has increased. Well, of course, we stopped at 2003. I believe that from then, our publication definitely has exponentially increased. And we found at that time that infections were covered in 18%, while the common problems such as musculoskeletal problems and skin problems were inadequately covered. And this has demonstrated to us the gaps in research locally. This version is free online. So in tandem with the bibliography work to stimulate primary care research, we formed the Malaysian Primary Care Research Group in September 2004. The aim is to promote high-quality primary care research in Malaysia. To date, we have over 200 members, and we are growing from strength to strength. This is our website. Please feel free to go into it. And we have held the inaugural first Asia-Pacific Primary Care Research Conference in 2009 in Malacca. This year, we are holding the third Asia-Pacific Primary Care Research Conference. Research provides us with evidence base for best clinical practice. It translates the evidence to practice is an essential task for all of us. Teamwork, not only within the discipline, but across the discipline is important to realize this. My involvement with clinical practice guidelines has portrayed the importance of multi-specialties and multidisciplinary work. This has promoted our discipline and facilitated us as primary care physicians in providing evidence-based clinical management and patient care. While publishing is a duty for all researchers to share new findings, evaluation work such as doing reviews and editing is another aspect of work that raises our standard in research. My involvement in these two journals closes the loop of academic work. And of course, we cannot not mention our icon of GP in the country, which is Dr. Rajakumar, that we have edited and essays of. Research is teamwork. It does not involve work within the department. It also involves work with other departments, multidisciplinary, interdisciplinary, in the university, out of the university, out of the country, and everywhere in the world. These are the people that I have worked with. And I wish to acknowledge this is my department, colleagues and friends. If you can see, some are taken a bit longer ago, some a bit later. You can try and identify where you are. And I would like to acknowledge a special thank to Professor Datin Dr. Chia, who has given me the support and encouragement, especially in the early years when we were a very, very small department, when there are probably only 3 of us. And we have grown. Now we have more than 12, 14. Our whole teams are here. A special thanks to Professor Nigel Mathers, who's my mentor and guru and supervisor for my doctorate degree, and who are here with me today. I'm grateful for that. Of course, I cannot not mention my other co-supervisor of doctorate, Professor Lau there, who I have worked with in many of my research work, and who have given me all the support and work throughout the days. Well, Primary Care Research Network is like a second home, isn't it? We have spent so many weekends together, arguing through the research, arguing through the networks, arguing through all these studies that really boggled our head all through the weekends. But I think it will be sweet towards the end, really. So you can all find your picture there. If I miss out anybody's picture, my apologies. I'm not a very good at photo taking. So these are the few photos that I can find. And some are by courtesy from Nick Sharina. And of course, there are people that I've worked with in other disciplines, and all my friends who are here with me today, who helped me some way or others with my journey in primary care research. I thank you. Some of you have come here, and some of you could not make it today, who have sent me text messages, who have sent me emails saying they really missed the great opportunity in this lecture. Well, I don't think you have missed much, but I have you in my mind and in my thought always. And of course, last but not least, is always my family, who have always been at the back suffering and traveling through this journey with me. Of course, this is the younger day. As you can see, I'm much younger then. They are much older now. Again, I cannot find a more recent picture. Isn't it awful? Well, ladies and gentlemen, in conclusion, diversity in research interest is a possible path in our academic career, given our broad-based discipline. Primary care research is flourishing in Malaysia, and we should treat our patient with our heart, and we should build knowledge capacity through research. And we, primary care research, can be the only rose and standing tall in a sea of green. Thank you.
Terima kasih Profesor Dr. Ming. Hadirin yang dihormati, kini mempersilakan berbahagia Profesor Datuk Dr. Rohana Yusof ke pentas untuk merumuskan syarahan perdana Profesor Dr. Ming.
Okay, ladies and gentlemen, I think Professor Khoo have taken us from mental health, women health, men's health, chronic diseases. That's for 1 hour we've gone through all that, and I think she have done a wonderful job. We can see her passion towards her work. I mean, she did all the survey before she did the management, and I think that's such a wonderful thing for medical people to do. The survey to answer all the questions and to strategize management, actually. And with this, I think I wish you all the best, Professor Ming, and I think you have been a wonderful doctor, and you have led the department to to successful times. So thank you very much, and Assalamualaikum warahmatullahi wabarakatuh.
Majlis mengucapkan terima kasih kepada yang berbahagia Profesor Datuk Dr. Rohana Yusof, Timbalan Naib Chancellor Hariban Pelajar Universiti Malaya kerana sudi mempengerusikan syarahan perdana pada petang ini. Dengan ini berakhirlah sudah majlis kita pada petang ini. Majlis ini merakamkan jutaan terima kasih kepada hadirin dan hadirat yang sudi hadir ke Syarahan Perdana Profesor Dr. Khoo Ming. Majlis menjemput hadirin dan hadirat sekalian untuk menjamu hidangan yang disediakan di Aras Lega Aras 4. Saya akhiri dengan wabillahi taufik wa hidayah. Wassalamualaikum warahmatullahi taala wabarakatuh dan salam sejahtera.